Hello, everyone. My name is İlke Çolakoğlu. I'm working as a business development supervisor at RMK AIMS Education and Simulation Training Center. And I'm very pleased to welcome you all to our fourth event of Koç Healthcare webinar series. Today's topic is Ocular Malignant Melanoma. And our leader for today's discussion is ophthalmologist Professor Murat Hasanreisoğlu. He will be lecturing us on several questions, several topics. What is OMM? What is at risk of developing OMM? What are the risk factors? How do we diagnose OMM? What is the treatment options for OMM? What is the prognosis and survival? After the presentation, we will be having question and answer session. I'm handing over the microphone to Professor Murat for his presentation.
Thank you very much, İlke. Can you hear my voice? Can you hear me well? Okay. So today I'm gonna, first of all, good afternoon. And today I'm gonna talk about ocular malignant melanoma. And then I'm gonna briefly talk about how do we treat them in Koç University Ophthalmology Department in conjunction with radiation oncologists here in Koç University Hospital. So I'm going to talk about a little bit of ophthalmological basics to tell you about a little bit of anatomy. And then after that, I'm going to talk about ocular malignant melanoma, types of them, and the risk factors that we know of, and then how to diagnose it, and finally, how to treat it and how to decide on the prognosis and survival factors. So as you can see here, I'm going to talk about the eye anatomy in order to make you understand a little bit more about what we are talking about. So basically, when you look to the eye anatomy, here we have the. Can they see my cursor? Can you see the cursor? When you see it, so here's the eyeball. We call it globe. And then this is the anterior part of the eye, and you have the eyelids. And when you look back, the eye is just sitting in a cavity, which is called orbits here. And inside the eye, we have two compartments, which is the anterior, like the most front part of it is called anterior chamber, and the back part of the eye is called the vitreous cavity. And then we have the neural structures, which are called retina and optic nerve, which transmits the visual. They act as a receiver for the visual signals. So they just transmit the images to our brain in order to make us see the objects. So when you look at ocular melanomas, basically melanoma is a cancer which develops from the melanocytes, which are melanocytes, and they can be found anywhere in the body, mainly in the skin, but they're also found in the eye, inside the eye, and also other parts of our body. So we can have melanoma where we have melanocytes, and melanocytes in the eye are found basically at the surface of the eye, which is called conjunctiva. Here we can see it briefly. And then we can have the melanomas at the skin of the eyelids. And then we can have melanomas inside the eye, where we have the pigments and melanocytes, which give the color of our eyes. There's an area called iris. And the iris is, as all you know, has different colors. And the difference in the color is coming from the melanocytes and melanocytes. They are pigments of the eye. And then we can have melanomas in the orbital tissues, which are the tissues found at the back of the eye, let's say. Here you can see a little bit of information here also. So there are like anterior inside the eyes. There are anterior uvl melanomas, as you can see here. They are found at the iris and ciliary body. And then we have posterior uvl melanomas at the back of the eye, which basically are the 95% of the melanomas that we diagnose. So little bit, if I may give a little bit of detail. So at the back of the eye, we have retina, it's neural tissue, and under it we have choroid, which is a tissue with full of vascular structures. There are a lot of blood vessels, and also there's a lot of stromal tissue, which we call, there's a lot of melanocytes there. So the main part of the eye that we diagnose melanomas are at choroid, and they are called choroidal melanomas. Okay, it sounds a little bit complicated, but I'm going to make it simpler. So what is a melanoma? So melanoma in the eye is the most common primary intraocular malignancy for the adults. So at the age of 18 and above, the most common malignancy in the eye, like tumor in the eye, malignant tumor, like bad tumor in the eye, is melanoma. And then they account, when you look through all the body, like skin melanomas and everything, they account 5 to 10% of melanomas. And for every million, we see 6 to 8 cases of ocular melanomas per million. So if you consider, for example, Turkey, we have like 80 million people living in Turkey. So each year we have like around 600 to 700 melanomas each year, like newly diagnosed melanomas. So most patients, they don't have any family history because the genetic predisposition is not that powerful. And these tumors can metastasize to liver and to lungs and bones through blood circulation. So they are very deadly tumors that can metastasize. And after the metastasis, the survival rates are not good. Basically, survival is 50%. At 10 to 15 years, depending on the nature and the size of the melanoma. So these are the like global melanoma incidence rates. So melanomas are they are the tumors of the people of like Western civilization, I may say, because they tend to be more common in Caucasian people. They are less seen in Hispanics and African people. That's because of the color of the skin. And when you look at it, basically, as the age increases, the risk of melanoma is increasing also, and it's peaking at 60 years of age. And there's no sex predilection. It can be found in women or men. As I said, in most cases are sporadic. That means that like there is no family history for most of the people, and the risk factors are basically they are seen mostly in people with fair skin, with blue or grayish iris colors. So they are basically seen mostly in Western, like Anglo-Saxon civilizations. So another, like there can be risk factors of the eye, but these are not relevant to our talk right now. So the diagnosis of UVL melanoma is basically clinical. So eye doctors see them and diagnose them basically just by looking at them. But we can take biopsies from them and we can just characterize their genetics. And there are like melanomas with better genetics or worse genetics. And it changed the metastasis rates and the survival of the patients. There are a lot of factors affecting the melanoma survival. But again, this is beyond our topic discussion. So there are like low metastatic potential tumors and high metastatic potential tumors. So what are the symptoms of patients with melanoma? Basically, most patients are asymptomatic patients. That means that they don't have any kind of visual symptoms. They don't feel anything until the tumor gets larger and larger in the eye. So regular ophthalmic examinations are very important. And sometimes when the tumor is getting bigger, like larger, and also if the tumor is located at the central vision area, those people may experience blurred and distorted vision, some types of visual field loss, or most importantly, like flashing lights, like light bulbs just passing in front of their visual fields. And in some cases, they may experience like cataract formations. They may feel ocular pain. And it like very advanced cases, they may have like glaucoma, inflammation in the eye, like and even a visible nodule even before the like without an ophthalmic examination. But again, I want to emphasize that 30–40% of the cases, like patients are they are asymptomatic, meaning that they don't feel anything. So differential diagnosis, basically, if you have a tumor in the eye, I mean, you have to consider all kinds of tumors that can be found in the eye. The main differential diagnosis is basically choroidal nevi, which means that nevi of the choroid, as in the skin, when you have like a pigmented, like dark colored brownish lesion, you have to differentiate it from nevi. Nevi is like a benign form of melanomas, and they don't need any kind of treatment when they are found in the eye. So we first of all, we have to decide if this pigmented lesion, like this nodule or whatever it is, first of all, we have to decide if it is benign or malignant. And if it is malignant, we call it melanoma. And if it is benign, we call it choroidal nevus. Okay. And when an eye doctor, when an ocular oncologist examines the eye and the patient with suspicion of ocular melanoma, the eye doctor or ocular oncologist can tell if it is malignant or benign. It's 94%, 95%, even 100% rates of accuracy, which means that out of 100 patients, almost 99% of them are diagnosed with either benign or malignant with very high accuracy. So most of the time there is no need for biopsies, and also we don't want any biopsies in the eye, which I will explain later. So we just check some clinical features. We do a lot of imaging tests in the eye to tell if the tumor is benign and malignant. Okay. So, we may do, your eye doctor, like your ocular oncologist, may offer you ultrasonography, which is very helpful in diagnosing these kind of tumors. And there is a clear distinction between the nevis and melanomas when you in the ultrasound. And also there are like advanced imaging modalities as optical coherence tomography, optical coherence tomography, angiography, fundus autofluorescence, which are basically ancillary tests that your ocular oncologists use to correctly diagnose UVL melanoma. Also, your eye doctor can order, or we generally order fluorescein angiography, which is a dye test that we inject a dye into your veins, from your vein, and then this dye basically is going into your eye, also into the whole vasculature in your body, and then we observe how this dye basically leaks in your at your eye vessels, the vessels that are found inside the eye, the retinal vessels or choroidal vessels, and this technique also gives a lot of important clues about the diagnosis of these tumors. Another thing is, so after those advanced imaging modalities, again, I'm telling it, just by looking at the eye with the naked eye, through an examination and with the help of those imaging techniques, we can almost 100% of the time, we can correctly diagnose the melanomas in the eye. So if you're diagnosed with an ocular melanoma, what is your survival rate? So it depends, as I told you, it depends on genetic factors. It depends on the how is the genetics inside the tumor is. If it is really bad, your survival can be shorter, like the prognosis is not good, it's the worst. But if the genetics of the tumor is better, then we expect a longer survival. Another factor is if the tumor is found in an early stage, as all cancers in human body, if we can diagnose this cancer earlier, and if the tumor is smaller, then the prognosis is far much better than the late ones. So if the tumor is getting thicker and larger, the survival rates are getting lower. I mean, the patients are unfortunately expected to live less than the ones that are early diagnosed. So here you can see that the slide, the survival rates. So if a tumor is found when it's small, the 5-year mortality, which is we look to the like a lot of patients, large cohort of patients, and there are a lot of literature about it, and only 10% of those patients are dying at 5 years of time. But if the tumor is larger, almost half of the patients, unfortunately, we lose because of metastasis if the tumor is larger. These are the rates when we treat those tumors. So these are all treated tumors. Even though we treat them, if the tumor is larger and larger, the survival is getting lower and lower. So the main point of this talk is basically get your eye examination as early as possible, so that if there is something wrong in your eye, then you have to be checked, and you have to get the right treatment as soon as possible. And this is mostly true for ocular melanomas. Basically, it's very important for ocular melanomas, as it changes the life and death expectancy of the patient. So how do we manage them? For example, if we diagnose the ocular melanoma patient, how do we treat it? So if the tumor is resectable, if it is not inside the eye, for example, if it is in the conjunctival area or like back of the eye, we try the surgical resection, which is a very good option for those tumors. But most of the time, if the tumor is in the eye, we don't prefer surgical resections. Instead, this tumor is a very radiosensitive tumor, which means that it is very sensitive to radiotherapy options. Then we use those options, and those options include radioactive plaques, which is called brachytherapy, external beam radiotherapy, or stereotactic radiosurgery. And then if those don't work, still taking the eye out with the whole tumor is a very good option if you want to save the patient's life. And after that, there are some adjuvant chemotherapy options to prevent metastasis, which is currently there's a lot of studies in that, and success rates of those chemotherapeutic agents are getting higher and higher. So here is how do we achieve treatment of those tumors with radioactive plaques? So let's say we have a tumor in the eye located at the inside the eye. So we just found that tumor, diagnosed it, and after the diagnosis, there are plaques. These can be gold or like silver plaques, and inside those plaques we put iodine seeds. And those iodine seeds constantly radiates certain types of radiation, and then the tumor is getting radiation for a constant time. We leave those plaques inside the eye, and then after predetermined the threshold of radiation, we just try to take them out, and that's generally 3 to 4 days. And after those 3 to 4 days, we take those plaques out and we examine the patient, and then we follow the patient basically once in 3 months if there's no other complication. And then those tumors respond to these radioactive plaque treatments very well. And this is basically the most, it's a very conventional treatment, but still that's the most tailored treatment for an ocular melanoma patient, especially for choroidal melanomas. And the results of this treatment is basically I think that this is the gold standard for ocular melanoma treatments. Of course, there are other ways to treat, give radiation to those tumors, such as cyberknife treatments and also linac-based treatments, which are basically machines designed to give a certain dose of radiation to a certain selected area in the body. This can be like major organs, or like this can be a tumor in the eye. And those treatment options are also very successful. But for small tumors, which are basically for the eye, which are smaller than 3 millimeters, 4 millimeters, because these radioactive plaques can be really small and can be adjusted, the best treatment option is still these radioactive plaque therapies. So I want to conclude my slides. I think I talked too much, right? 20 minutes. Do I have time? Okay, so there are other options, as I told, and then we have also transpupillary thermotherapy, like laser treatment options. These are basically adjuvant therapies after the other major treatment options. And lastly, unfortunately, if we cannot succeed the radiation therapy, which doesn't often happen, but almost like 5 to 10% of the cases, we may take the eye out to make the patient live longer. And this is a big sacrifice, but sometimes it's needed. And also, I want to again emphasize that the goals of the treatment of eye tumors is, first of all, save the life of the patient, and which we will do anything, and then save the eye, like the eye itself, the cosmetic appearance of the eye, and then save the vision. And this is true for all ocular malignancies, I guess. Thank you for listening to me, and then I will answer questions.
Thank you very much for the beautiful presentation. During your presentation, we have received several questions from the audience. I will start with the first one. What is the most common presenting symptom in patients with ocular melanoma you encounter in your clinic?
Okay, as I told you, as I told in my presentations, in most cases, they don't even realize that they have a tumor in the eye. It is an incidental finding. But if there is a symptom at all, the visual disturbances, like people experience like decrease in vision. They don't see well. They see a little bit distorted. And also these like flashing, like lights passing in their visual field is a very common symptom for melanomas. Like they tell that I have a light ball just passing through my visual field constantly. And also in advanced cases, as I told in my presentation, they can just present any kind of inflammatory symptom, like pain in the eye. Also, in advanced cases, you can see the melanoma coming out of the eye. But that's very rare in our era of manual era, let's say. It's very rare.
Thank you very much for the answer. The second question is, what is your success rate with plaque brachytherapy? Did you have patients requiring enucleation after brachytherapy?
Of course, I'm gonna give the accepted success rates worldwide. It's basically for plaque brachytherapies or plaque radiotherapies, the success rates are over 90%. But success is defined as curing the tumor in the eye, which may not always save the vision or save the eye, but curing the tumor in the eye is over 90%, and almost 95% of the cases they don't need any other treatment for their tumor. But still, we have 5% of the eyes which are not really sensitive to radiation, and then they will need additional therapies.
Thank you for the answer. The next question is, what complications did you encounter with plaque brachytherapy?
So plaque radiotherapy basically is a radiation therapy. So we are giving radiation into the eye. Although it is very localized, it still has some radiation complications in the eye, which may be like hemorrhages in the eye, visual decrease in the eye because of radiation, cataracts, glaucoma, and also dry eyes, some kind of eye irritation for longer periods of time. But all radiation treatment options, they have those complications, and it's worth doing that despite those complications, because the other choice of treatment is taking the eye out. So in this, again, like in 2021, we don't want to take the eye out, but we want to treat the eye as it should be, and then we have other treatment options for all these radiation complications. And most of the cases, they survive those complications, and we are happy with that. So of course we have complications, but the rate it depends on the tumor size. If the tumor is smaller, it means that the eye is receiving less radiation. And if the tumor is larger, it means that the normal ocular tissues are getting more radiation. So it depends on how large is the tumor and how much radiation it received during the treatment. But in any case, we treat those complications even though they occur.
Thank you very much for the answer. The other question is, are there any contraindications for plaque brachytherapy?
Okay, there is no certain contraindication, but if the tumor in the eye is too large to treat with plaque radiotherapy, then we may decide not to do it, because the cost effectiveness is not worth to do it, because then we know that if the eye is like filled with a large tumor, then we know that the radiation effects, the side effects, will basically prevent the eye to see or even to keep its shape. So then we don't want to give an extra burden to our patients. We just move on with other treatment options, such as external radiotherapies, like stereotactic radiotherapies, or simply taking the eye out and saving the patient a lot of extra visits.
Thank you very much for the answer. This will be the last question.
Thank you very much for the answer. This will be the last question. Is transpupillary thermotherapy used in ocular melanoma with distant metastasis?
So transpupillary thermotherapy is an option. It's a laser. Basically works on in a way that it increases the temperature inside the tumor and basically cause the tumor death through thermal, let's say, toxicity. Okay, so for distant metastasis, we cannot use it because it's directed to the tumor, and it can only be directed by visualization of the tumor. And if we have a tumor inside the eye, we can see it and we can use it as a treatment. But distant metastases are generally in the liver and also like bone and like lung. Those tissues are basically not visible through just by looking at them. So we only use this treatment option for ocular tumors, and not as a sole treatment option, but an adjunctive treatment, where we want to give an extra treatment effect after plaque brachytherapy or any other treatment we have.
Okay, thank you. This will be all for today. We would like to thank Professor Murat and for sharing his time, and our participants for joining us for today. And hopefully we will meet again in our next webinar. Wishing you a pleasant day. Bye.